Welcome everyone, and thank you for joining us this evening for the MyIBD Learning webinar series. Today's webinar will be focused on ostomy tips and tricks, and we are going to hear from expert faculty and IBD patients about common ostomy surgeries, how to care for an ostomy, and helpful tips and tricks on managing life with an ostomy. My name is Renat Last, and I'm the Manager of Pediatric Education and Resources at the Crohn's and Colitis Foundation. I am pleased to be facilitating tonight's program. The MyIBD Learning webinar series features different topics each month. By registering for tonight's webinar, you've automatically been registered for the series, which takes place on the third Thursday of each month. As a reminder, our next webinar will be taking place on Thursday, November 18th, and it will be on navigating eating around the holidays. We encourage you to explore the webinar website to learn more about our monthly programs and read about our presenters. Under the homepage, you can find different tabs to watch recordings of previous webinars, learn more about upcoming webinars, and connect to a local support group or your foundation local chapter. To learn more about the event platform, you can go to the Navigation Q&A tab. If you have any questions during the program tonight, please visit the live discussion and a virtual help desk attendee will assist you. A few housekeeping reminders before we begin. All the presentations will be recorded and accessible to view after the completion of tonight's program. If you have any questions for our presenters, please feel free to type them in the Q&A box at any time throughout the program. I would like to thank our event sponsors, Gilead, Janssen, Takeda, and Bristol Myers Squibb for supporting the MyIBD Learning webinar series. Their support enables the Crohn's and Colitis Foundation to continue to provide important education for patients and caregivers. Now, I would like to introduce this evening's expert faculty who will be presenting tonight. Dr. Daniel Chu is an associate professor in the Division of Gastrointestinal Surgery at the University of Alabama at Birmingham. His clinical practice specializes in the spectrum of colorectal diseases, including inflammatory bowel disease. And Jennifer Giannatino is a nurse practitioner for Yale New Haven's Hospital Ostomy Program. She completed her wound ostomy continence training at Emory University and is certified as an advanced practice provider in wounds, ostomy, and continence. She's a member of the American Association of Nurse Practitioners and the Wound, Ostomy, and Continence Nurse Society. Thank you both for presenting tonight, and Dr. Chu, I will pass it along to you.
Great, thank you so much. Okay, hopefully everyone can see my screen okay. So good evening, and thank you to everyone for being on the call tonight. And thanks also to the Crohn's and Colitis Foundation for this opportunity to share some perspectives on ostomies and surgery. And I am a colorectal surgeon here at UAB. And so a part of my practice is doing and constructing ostomies for many patients. So I don't have any commercial disclosures, but do have some research support, and we will not be talking about research tonight. So when I show this picture, I think this picture evokes a lot of thoughts, fears, ideas, questions. And many of us on this call have likely heard about ostomies, either experiencing it personally or has seen it through friends, family, and colleagues. And I do hope that this talk will shed some light on ostomies, make it more understandable, and also maybe make it less scary, because it can be very much so when patients and families first experience an ostomy. And besides talking about just what an ostomy is, I do hope to answer some questions on why an ostomy needs to be done, when they're usually done, and how we actually do it as surgeons. So I think the first thing is just some basic terminology. The words stoma and ostomy are oftentimes thrown around a lot, and I will confess they do mean the similar things, but a stoma is more of a general term. It simply means that there's a hole or an opening somewhere on the membrane, whether it be the bottom of a plant or the human body. An ostomy is more specific. This is more of a surgical term, and the one that tends to be used more often, and really describes not just an opening, but an opening where intestines comes through to evacuate waste products, whether it be stool or whether it be urine even. Now, why do we need to do ostomies? And there are two big reasons. The first is simply to evacuate stool or waste products. The human body is designed in a way that we cannot just have it inside ourselves. It has to come out somewhere. And so that's clearly the most obvious reason why an ostomy has to be made. But reason number two is probably the reason that we see it also a lot, and it's to divert stool. And what do I mean by that? Why do we need to divert stool? Well, if you think of the intestinal tract as a long pipe or even like a river, downstream of that pipe, of that river, there can sometimes be major problems. In colorectal surgery, we oftentimes make a lot of connections or anastomoses downstream. And so sometimes we have to protect them. And that's where an ostomy comes in. At the same time, there can also be problems downstream of infections or open sores or wounds that just won't heal. And in those situations, we also have to bring up an ostomy to divert the stool to let that area heal. And finally, sometimes patients can have obstructions, either a stricture or a mass or something going on downstream that we can't go in and take it out for whatever reason. And in those cases, you have to have some way to let the waste products out. And so that's another reason why we sometimes have to do an ostomy. Now, I hope to illustrate this with some pictures. I do think everyone understands things much better with visuals. So when we do surgery for inflammatory bowel disease, surgery is always two pieces. There's a resection, meaning we have to take out the part that's bad, and there's a reconstruction. How do we put things back together? So this picture shows a typical abdomen where you have your small bowel in the middle and your colon with your appendix hanging there coming up, and stool flows right around the colon all the way down to the anus where stool comes out. I've shown in red just as one example of a piece of intestine that's going to come out. This piece happens to be the sigmoid colon. So if someone has a problem with the sigmoid colon, this is what we would take out. So that's the resection. But as you can see, after you do the resection, there's two pieces that are left, two ends that are left. And so the big question now is, what do you do with those two ends? And that's what we mean by reconstruction. How do we put things back together? And this slide really just shows you all the major principles that we use in colorectal surgery. After you resect that section of the colon, there's actually only three ways to put everything back together. And it just happens that two of them do require an ostomy, Plan B and Plan C. So what do I mean by these three plans? Well, Plan A is what everyone wants, what everyone hears about and might expect. Plan A is when you have those two ends and you join them together in what we call a primary anastomosis. So you put the bowel back to bowel, and the intestinal tract is in one line again, and food will come right through and waste products will come right through the bottom end again. And you can see in those red lines there, I'm trying to illustrate how we put those together. So that's the join, that's the anastomosis. No ostomy here. And certainly while we wish Plan A for everybody, as you can see, there are two other plans, B and C, because not everything works out fine sometimes with Plan A. So what's Plan B? Well, Plan B is when we make that join, we make the connection, but we don't trust the connection for whatever reasons. We don't think it will heal right. Because if this connection leaks, it is catastrophic. People can die when that happens. So it's really important to make a judgment call of when you do Plan B. And when will we do that? Well, when we make this connection, sometimes patients' nutrition isn't great. Sometimes patients are on high dose steroids. Sometimes patients are in the ICU and just on really, really sick. In those cases, you really shouldn't do just Plan A. You usually do Plan B. So as you can see here, we make this connection, but because we don't trust it, we go all the way back upstream, all the way back, all the way to the small bowel, to a section of the last part of your small bowel called the ileum. And we bring it up as an ileostomy. And the word ileostomy, this follows under the umbrella of ostomy. This is just a specific type of ostomy. And you can see it's named after the piece of intestine that's brought up. And so this is what we call an ileostomy. So you can see now that the stool will come down through the small bowel, but then come through the top hole here and into a bag. And so very little waste material will go downstream into this connection. So it protects it, gives it time to heal, and then about 6 to 8 weeks later, we can check this connection with an enema study. And then if everything looks good, we can get rid of the ostomy and sew it together, plunk it back inside, and you're back in line again. So that's plan B. And we do plan B a fair amount in IBD surgery. Now, plan C is the one that also has to be here. This is in cases when we do not make any connection. There is no joint. There is no anastomosis. We bring the colon straight to the skin as an ostomy. And this one happens to be called a colostomy. And as you can see here, stool does come into a bag on the left side of the patient, and there is a long blind end that's left behind. Now, this is not also meant to be permanent. This can also be reversed, as you can imagine, where we can convert from plan C down the road to a plan A again, or sometimes we even have to go to plan B and then finally a third operation to reverse the ostomy here. But the point of this slide, and this is a critical slide that we show also all of our trainees, is that these are the principles of reconstruction when we rebuild the intestines. And any surgery that's done is some variation essentially of this. But hopefully you can see then some reasons as to why we have to do an ostomy. Now, to illustrate it just a little bit more, to go tie it back to that other slide in terms of why we do this, I talked a bit about protecting these connections or these joints. And so you can see for plan B, that's what plan B does. Now, we also sometimes have that problem of obstruction, so a stricture or a mass. And for some reason, we can't just take it out at that time. In those cases, there's also a reason to oftentimes do plan B, and then sometimes even plan C. And then the last one is this distal wound or issues. This happens in Crohn's disease, where in Crohn's, some patients can have really severe perianal disease, just tons of fistulas, tons of abscesses that just won't heal. And sometimes in those patients, we have to pull up a plan B, pull up an ileostomy to prevent stool from reaching this area and from feeding the fire is what I described. And so that lets things quiet down. And then down the road, once things are under better control, you can then reverse the ostomy. So these are some of the reasons of why we do an ostomy. Now, what about the second question? When do we do an ostomy? Well, ostomy surgeries, classically from our perspective, happens under two situations, elective ones and emergency ones. And usually it's a part of some other bigger operation, as you might imagine. Now, when do we do surgery electively? Well, it's for the same reasons why a surgeon would do surgery for inflammatory bowel disease. There's failure of medical therapy. So patients who are on high-dose steroids that can't get off of steroids because they have so many symptoms, biologics, complications. They've been on 4 different biologics, and again, no biologic seems to work, or even extraintestinal manifestations. These are all the kind of the indications for doing elective surgery, whether it's ulcerative colitis or even Crohn's disease. Now, clearly we do surgery also for cancer and for precancer and for complications of IBD, such as strictures or fistulas. So these are the elective reasons of when we do surgery for IBD. And in each of these scenarios, there is that possibility after we take out that section of the problem that we might have to do a plan B or a plan C. Emergencies is the other big condition where we may have to do surgeries. This is when patients have gross perforations, holes in the intestines, and patients are awfully sick when this happens. Or patients are completely obstructed or having massive bleeding. Under these situations, we oftentimes have to do emergency surgery. Now, whether it's elective or emergency, oftentimes something has to come out. That's that resection that I talked about earlier. But there's also that reconstruction. And so this slide, I think, hopefully ties in the reasons of why we do ostomy surgery to these indications of when we take patients to the operating room. And as you can see here, whether elective or emergent, after we remove that section of the intestine that has been causing the problem, we have to make a decision as to how we rebuild the intestines. And this is a clinical decision at this point. Now, I will say that the probability of doing a plan B or even a plan C is much higher under emergency circumstances than compared to elective circumstances, which is why in IBD, we really try to get patients to be, if possible, in a more elective situation than an emergency situation. So hopefully that explains a little bit about when we do these ostomy surgeries. Now, what about the how? And this is more of a technical piece of the talk here. And I think there's really three important steps of making an ostomy. One, you have to choose which part of the intestine to use, whether it's the small bowel or whether it's the large bowel. And there are some major decisions that are made there because a small bowel puts out a lot more fluid than the large bowel. So you have to pick which piece to use. Then you obviously have to pick the location on the abdomen and then make the actual hole or the stoma itself. This is actually not a trivial decision either because everyone has a different body shape, different body curves, folds. And so you have to take your time to choose a location because if you choose the wrong location, that is a bunch of grief for patients and families down the road and for our WCN nurses. So after you pick a location to make the hole, then you have to raise and mature that part of the intestine and mature it. And I'll show some pictures of this. So it's not, I would say, terribly complicated in terms of the procedure itself, but we follow these three principles. And of course, after the surgery, that's also a big piece. And where we have to partner with our WCN nurses because a lot of care happens after the surgery in terms of how to do the appliance and then the different care and different issues that can come up after a new ostomy. So when we talk about choosing which part of the intestine to use, I alluded to this in the earlier slides. We can do small bowel ostomies or we can do large bowel ostomies. Large bowel ostomies or large intestine, since it's also called colon, that's why we call those colostomies. Now, small bowel, most commonly we use the ileum, which is the last part of the small bowel. And that's why they're oftentimes called ileostomies. Now, it is possible for patients to have more proximal small bowel. The middle piece of the small bowel is called a jejunum. And so that's called a jejunostomy. So a lot of different wording here. Now, besides choosing the part of the intestine to use, there's also the configuration. Because as I showed you in the plan Bs and Cs, some of them are what we call loops, which is just basically one side of the intestine that's brought up and opened, or some of them is the full-on end of the ostomy. And so this is the two main configurations of an ostomy. And so you can imagine when we talk about reversing ostomies, a loop ileostomy is much easier to close and reverse than an end ostomy. And so that factors also into some of our decisions. Now, after choosing which piece of the intestine to use and the configuration of it, the next big piece is picking the location on the abdomen. And there's a lot of science and a lot of experience behind this. And again, we partner heavily with our WCN nurses to make these decisions. And this diagram simply shows the general principles of picking the location. And the key is it has to be in an area that is ideally through the middle of the rectus muscle to prevent hernias from forming. And it has to be in a location that you can easily see, because if you can't see it, it's going to be impossible to pouch it. And so this is some of the major principles of locating it and making the hole. And when we make the hole, we do make it about 2 finger breadths wide. And you can see this diagram showing us making the incision through the skin, through the rectus muscle, and then making the hole all the way through. And basically it's through this hole, this stoma, that we pull up that intestine, whether it be the small bowel or the large bowel. And the next slide will show you how we mature it. So raising and maturing the intestine for the ostomy is on paper, straightforward. You basically pull up that piece of intestine. Now, it has to be no tension, and it has to come up a couple centimeters above the skin. And the reason for that is because we use a technique called the Brooking Technique for all ostomies. Whether it's an end ostomy, like shown here, or even whether it's a loop ostomy, which I showed earlier, the key is we have to basically make it look like a bud and fold it over itself with sutures so it buds above the skin. This makes it easier to pouch, and our WC and nurses will not be mad at us if we make this look much better like this. Now, at the Mayo Clinic, they send us to St. Mark's Hospital in London. And in London, the colorectal surgeons keep telling their trainees, make the ostomy look like a walnut whip. And I had no idea what a walnut whip was, but it is actually a Nestle-made candy that looks like this. And so you can see that their trainees, their goal is to brook the ostomy so it looks like almost like a little volcano. And this is just much easier to maintain and is a good ostomy. So hopefully I've just shared some thoughts from a surgeon's perspective on ostomies, why we do it, when we do it, and how we do it. Certainly, we very much appreciate that new ostomies and old ostomies, again, they can be very scary, and for patients can seem like the end of the world. But I do want to assure patients and families that there are clear reasons and safe ways for us making an ostomy. And while a lot of ostomies are temporary, it is important to point out that some can be permanent too, and for different situations. But it's also important for me to stress that for either, patients have full lives ahead of them. And we're going to have some great stories from patients' own experiences to share with the group here. So these are just some Instagrams, because there's a lot of Instagram out there and social media on patients and families with ostomies, and you can see very full lives for everybody. So with that, I'll be happy to take any questions at the end of the talk. Feel free to email me. I'm always good with emails. Also on Twitter too, for any questions that anyone might have. And again, thank you for everyone's time tonight. And now we're going to hand this over now to Mrs. Giannettino.
Let's see. Okay. Thanks, Dr. Chu. I appreciate that, and thank you for the wonderful talk. I also want to thank the Crohn's and Colitis Foundation for inviting me to speak tonight. My name is Jen Giannettino. I am a wound and ostomy continence nurse at Yale New Haven Health in New Haven, Connecticut. I've been working in some capacity with ostomy patients for the last 15 years through nursing and as an inpatient nurse practitioner, and now outpatient wound and ostomy. So hopefully I have some tips and tricks that we can share with you that might make your journey a little bit easier. I have no personal disclosures. I just wanted to, kind of start the talk with an opening thought. When we begin to long for a life without difficulties, remind us that oaks grow strong in contrary winds and diamonds are made under pressure. And this was just a quote from a minister who was opening a session of the Senate in the 1940s, but I just thought it was an interesting point to make here. And I would encourage you all, as you journey through managing your inflammatory bowel disease, to think of yourselves as oak trees or diamonds in the making. So ostomy population in the United States, you're not alone. I think this is the most important point on the slide. There are, hundreds of thousands to a million people in the United States who have some type of ostomy at any given time. As Dr. Chu mentioned, some of them are temporary, some of them are permanent. So that's why the number varies year to year. There's many organizations out there that offer information and support, such as the United Ostomy Association, the organization Crohn's and Colitis Foundation, who sponsored these wonderful talks, and the Wound Ostomy Continence Nurse Society. Many supply manufacturers are also very invested in your success as a patient, should you encounter an ostomy surgery along your journey. And the one thing that I always ask my patients when I meet with them preoperatively, ostomy may or may not be a new experience for you, but just please have patience with yourself as you navigate this journey. Allow yourself to feel feelings. It's normal to be anxious. It's normal to be nervous. And everybody has an adjustment period. And so, as you are going on your own personal journey. Just have patience with yourself, which sometimes is a lot easier said than done, I think. So one of the things that, I've kind of learned over the last many years is that resources in communities vary widely across the country. So I kind of look to guidance from UOA Patient Bill of Rights as far as what should I be looking for, where and when I'm going to have my surgery. So you want to look for a place that's going to provide you preoperative teaching or preoperative resources, and that includes, going over your surgical procedure, what the expected post-op course would be, what the type of ostomy is, what you need to know to care for it. And then also something that Dr. Chu referred to during his talk, which was stoma site marking, which is taking a look at your abdomen, the contours, the folds, the skin, maybe prior surgical sites, to decide where is the best place in your body to place an ostomy where it's going to make it the easiest for you to care for. Also, just the hospital where you're going to have surgery. Do they have inpatient wound ostomy continence nurses? There are plenty of nurses who don't have specialized training, perfectly capable of providing excellent care and education. But it's good to know what you're walking into and what type of learning you might encounter after your surgery in the hospital. And then post-discharge, will you be looking at a short-term rehab stay versus going home with visiting nurses? Am I going to be discharged home with supplies? And who are going to be my appropriate contact people for what types of problems when I leave the hospital? So many supply options, and I think this is one of the things that patients who have an ostomy are kind of intimidated by initially. There's one-piece pouches where the wafer, the sticky part, and the bag are in one spot or together, and two-piece pouches where the wafer and the pouch come separately, and you have to snap them together, kind of like a Tupperware or a sticker connection. Closed-end pouches, which you can see there, are the ones that don't have the drain, and those tend to be used a lot by colostomy patients because you don't have to, and it makes it so that you don't have to drain your stool into the toilet. There's also flat and convex options. The flat options are nice for stomas that protrude nicely from your abdominal wall. Convex can be used in some other cases where your stoma is flush or has become retracted from the skin. It can also be helpful with stomas that have high liquid outputs, like ileostomies or jejunostomies, and it helps the stoma to empty more readily into the pouch. There's also cut to fit, which means that you have to cut the hole in the opening of the ostomy bag or wafer. And these are nice in the early learning stages of having a stoma because your ostomy will change a little bit over time. We'll talk about that a little bit later. And they're also good for irregularly shaped or oval stomas. And the pre-cut ostomy bags or pre-cut wafers are nice after you have healed from surgery, and then you no longer have to worry about continually measuring, hopefully, your stoma, and you'll be able to fit into a standard or a size continuously over time. Let's see, accessories. There are so many accessories out on the market. I like to operate on a less is more. Try to simplify your routine in the beginning. When you're learning how to care for yourself and your new ostomy, it's important to have a checklist of all the recommended supplies that you might need at a pouching change, so that when you are getting ready to care for your stoma, you have everything all in one place and you're not having to run from the bathroom to the bedroom to, maybe a medication cabinet or whatnot in order to grab these accessories that you might need. There are many things. There's paste and paste strips. These are utilized close to the stoma along with barrier seal rings, which are down in the bottom left of this picture. And they can be used all to create even pouching surfaces. So if in and around your stoma there's a dimple or a skin divot, these are items that you would kind of use to caulk the surface to make it flat and easier to apply a pouch and get a good seal. Barrier strips, the things that are in the center there, we call them smiley faces in some instances. If you look at them, they look that way. And those are to secure the outer seal of the ostomy wafer. They can be used under the ostomy wafer too if you have a peristomal wound and to secure a dressing. And then there's stoma belts, and there's also deodorants, which we will again revisit in a short while. So how do you get your supplies? At our institution, we have our inpatient WOC team who will recommend the best initial pouch for you during your hospitalization. As I mentioned before, pouching needs change over time. So within the first 6 to 10 weeks of your operation, the size and measurements of your stoma may change, and recommend that you measure your ostomy with a measuring guide, at least a minimum of weekly. And if they're available in your area, seek out an outpatient WOCN to follow up with. Some WCs are now offering more telehealth options that, kind of is one of the better things that may have come out of this pandemic. So there's a lot more telehealth available out there for people who may live in a remote location. Ordering supplies. This can be a little bit of a challenge, and I think something that maybe not always well understood. Ostomy supplies are considered DME, which means they're durable medical equipment and you need a prescription for them. There are organizations called manufacturers, which, simply explained, they're the ones that produce the ostomy supplies and products. They do provide patients with samples if you request them, but they are not able to fill your prescription. To get your prescription and your supplies, most often it's done through a mail order system, and there are several distributors in the country, very similar to a mail order pharmacy setup, where you request the supplies that you need, you provide them with the prescriptions, or your physician's office provides them with the prescriptions, and they send you your stuff in the mail. And then, sometimes you don't have insurance, or maybe you might need to pay cash for something that's not covered. There are the manufacturing companies have financial aid packages, as well as some of the organizations like United Ostomy and Crohn's and Colitis. They have resources for you to look into on their websites, and mechanisms for you to get supplies through them. And sometimes local support groups can be an excellent option. So now you have your stoma. Peristomal skin tips, just very simply, recommended that you cleanse with warm water only. If you need to use a mild soap, that can be okay, something like Dial. But what you want to do is avoid anything that's going to have a ton of fragrance, or maybe lotions, aloe in it, because it can interfere with the seal that you'll get from your ostomy bag. When it comes to peristomal problems, early detection is key, and it is very helpful in the management of these issues. So when you are changing your pouch, you want to look at the area around it for any redness, irritation, any wounds, or any painful areas. I'll look at the back of the wafer when you take off your ostomy appliance, and just check and see if there's any areas that look like they might have been saturated by stool or fluid, because these can be predictors of maybe future problems with your skin, areas of future problems with your skin. And inflammatory bowel disease, you want to pay particular attention to any areas of discomfort or any wounds with discoloration. There are some extra intestinal manifestations of, Crohn's and ulcerative colitis that may present as skin problems. So just something to kind of keep in mind. And if you were to come across any of these issues, certainly contact your surgeon's office, or if you do have a WOC that you're working with, that is something that they can help you manage. All right, so moving forward, now we have our ostomy, and we're at home, and we're in recovery period. So these are things that become important to a lot of patients. So they get nervous about odor control. And I would encourage you to kind of remember, as my son was growing up, there was a book that's called, everyone poops, right? And the manner of bodily waste is excreted in a patient with an ostomy is different, but everybody has smell, kind of associated with that process. So, odor with an ostomy is normal, emptying and pouch changes, but it's important to remember that the manufacturers have worked really hard to make pouches odor-proof. And as long as you have a good seal at the skin, and you have a clean drainage spout if you're using a drainable bag, there should be very little and likely no odor associated with your stoma. Lubricating deodorants, oral deodorants, and other fluid absorbing crystals can also be used to help you manage odor, while you have your stoma. And another concern for patients often is gas and noise. The gas should be taken care of. If you have a pouch with a filter, it should be able to filter through the charcoal filter and preventing any sort of smell. There are filters that can also be added to pouches that don't have filters. The one thing about the filter, you want to be careful to not expose the filters to water or moisture. So most of them come with a sticker, or you can cover them with some tape when you're taking a shower or you're going for a swim. And the reason being is if the water gets into the top of the filter, it prevents it from functioning appropriately. And also with gas and noise, you think about food choices, and you can kind of learn as you're growing with your ostomy to recognize which types of foods you can expect what type of outcome from your stoma. So high gas producing foods like asparagus or beans, beer, hard-boiled eggs, spicy foods, maybe some things that you want to pay attention to what happens when you eat them and you have an ostomy. And then, just remember, everybody's GI tract makes noise. And if you're concerned that it's something that's going to be noticeable to people around you, there are ways to muffle or cover up the sound. And there's also, you can kind of follow up at some noises with, oh my goodness, I'm just really, really hungry. If it's not, in an effort to cover up, the noise that they may have heard. And then there's also concealment and support garments, pouch covers, as you can see in the bottom corner there. Belly bands that you can use to cover up the pouch if you'd like to. And there's some companies that make specialty clothing and support belts for patients who want to play sports. And contact sports, they also have things that are like a little bit more of a harder cover called a stoma dome that you can use to protect your ostomy for when you're playing that particular activity. And then just make sure that you identify your cheerleaders. You want to develop some key relationships with coworkers and students and supervisors, depending upon where you are in your life, if you're in your student or your working life. You want to make sure you know who's on your team and who you can confide in should you need to talk about something when you're at work or school. Exercise and activities. Your ostomy shouldn't define what you do. There are plenty of people out there who have stomas, who have lived a full life, as Dr. Chu alluded to earlier. Surgical recovery, depending upon your operation, 6 to 8 weeks certainly varies by surgery, varies by surgeon. It varies by how you went into the surgery, if it was urgent, emergent, if you were, had nutritional issues around high dose steroids, etc. So this varies, but generally speaking, light aerobic exercise is good for you, in the hospital and once you go home. And by that I mean walking, going up downstairs are okay. There's usually lifting restrictions in place to prevent hernias. This applies to laparoscopic surgeries too. And after your surgical recovery, you can start to resume your normal activities under the guidance of your surgeon and WCN if available. And I have some recent patients just to kind of give you an idea of the types of things that people are capable of. One of my patients has become an ostomy Instagram spokesperson. She makes all kinds of videos and posts all kinds of strategies for how to manage things on a daily basis. We had a rodeo cowboy, police officers, firefighters, rock climbers, triathletes, and people who like to stay home and sew. So whatever it is that you like to do, I think it's a tragedy to kind of let an ostomy stay in the way of what it is you might like to accomplish. Dietary tips with a colostomy, you should be able to return to your normal pre-op diet. That of course may include some restrictions depending upon what type of diet you follow for your inflammatory bowel disease. With an ileostomy, you do have to focus a little bit more on hydration. Although hydration is important with a colostomy too, to avoid constipation. The issue with ileostomy is avoiding dehydration. So beware of if you're feeling always thirsty, if you have a dry mouth, if you have some dizziness with position changes, and you're urinating less frequently. These are all signs of dehydration. And so you may be asked to do something like measure your output for the first little bit of time that you are recovering from surgery, either in the hospital, they'll monitor it for you there, or they'll have you do this at home too, just to make sure that on average, your stoma is not producing too much fluid. There are medications and strategies that you can utilize to manage this, should this happen to you. And one of them might be initially to sort of pay attention to the sugar content of fluids. A lot of times patients will reach for something like a Gatorade or a Powerade, which in some instances is fine. But you also want to pay attention to the sugar content, because the sugar can actually increase the output of your ileostomy as well. And there's plenty of recipes out there for oral rehydration. For those of you lucky enough to have access to nutritionists, they are often very helpful in managing these strategies, or helping you to manage strategies for hydration. Low fiber and low residue diet is often important in the beginning of recovery from an ileostomy surgery. The diameter of your small bowel is fairly small, and as with any injury or aggravation to bodily tissue, there's swelling, and the concern there is if you eat a handful of nuts or a large entree salad, that your food may get stuck at the opening when it's trying to get out of the stoma, and that can cause a lot of pain. So it is something that you want to pay attention to. And also, as I mentioned before, just repeating again, getting to know your output and how your body responds to different types of intake. Preparation for traveling is key. Everybody has their own sense of adventure, and whether it's just going out to the local supermarket to buy food to make an excellent dinner, or going on an adventure and hopping on an airplane and traveling. So maintain a small kit with you if you're going, for whenever you're going out, so that you have the capacity to do a pouch change if you need to, if you're out and about town. And then if you're going to go away on a vacation, pack extra pouches and accessories, especially if you're going overseas. You want to look into sort of stocking up and bringing as many things with you as you can. And in terms of being at the airport, the TSA, if they needed to do a pat down for whatever reason, you can request to have a private pat down, out of the eye of the general public. And a lot of times patients find that to be helpful should they find themselves in that situation. In terms of other things, school, you want to look at, 504 plans are available to students who are in the public school system who require accommodations for a medical condition. And for this can include ostomies. And so you can have a plan specialized for you that includes things like, if you need daily medications, your special dietary needs, additional bathroom privileges. The Crohn's and Colitis Foundation has a wonderful website and page on how to sort of navigate these challenges within a school system. And the 504 plan can pertain to all levels of education through college for any schools and graduate schools that accept federal funding. And so if you're in a college situation, consult your Disability Resource Center and see what kind of resources they might also have available for you. And in terms of work, there's American Disabilities Act. Many people see their ostomy as a lifesaver and not necessarily as a disability, but in terms of the law, patients with stomas are covered under the ADA. And so to look into sort of what resources your work may be able to do to accommodate you as you adjust to life back at work. And just to be cognizant of any heavy lifting or movement restrictions that you may also have after surgery, especially in the immediate post-op recovery period. And being close to people is a normal part of the human experience. So, moving forward after stoma surgery is also going to include things like relationships with friends and intimate relationships with significant others. It is possible that surgery can interfere with sexual function. It's more likely for a cancer operation, but sometimes it can be with IBD. So it's an important conversation to have either with your surgeon or with your WOC. And having an ostomy can cause or exacerbate existing body image issues. So, make sure you do have some people in your life, friends, family members that you can share your concerns with, or seek professional help if needed on how to deal with managing the expectations of having an ostomy and being in a relationship. Let's see, resume dating or intimate relationships when you feel ready. There is specialty clothing and intimate apparel available. And there's always a challenge of when you're starting to date someone new, when and how to share this information with them. And I think that is something that you can also discuss with friends and with your WOC if you're able. Other special considerations: people with ostomies have healthy babies. Pregnancy is possible. Can require short-term pouching changes for the growing belly. You're probably going to be followed closely by your gastroenterologist and maybe a high-risk obstetrician. But you can have a baby and go on to raise a healthy baby. And then for pediatrics, smaller bodies, there are smaller pouches. I find that the kids tend to outgrow the kids' pouches fairly quickly. Usually by age 3 or 4, they're in a either mini adult pouch or a regular size adult pouch. But as with kids, and as with some adult, with adults too, you need support people. In this case, it would be the parents, to sort of be taught skills alongside the patient, to help care for the ostomy. And there are some skin issues pertaining to pediatrics and products. So make sure that when you're looking at a product to use for an ostomy on a child, that you are looking at manufacturer's instructions for whether or not it has been tested in children. And again, use the resources that you have available to you in terms of the organizations and the people in your life that can help you to sort of evaluate this. And just as a closing sort of remark, this newbie ostomy is a very helpful, fun website to kind of peruse. But I found this quote: step by step, day by day, the stigma about ostomies is taking a backseat to the reality that life with an ostomy can be just as good, if not better, than life without one. So with that, I think we're going to hand it back off to Renat to talk about some patient stories.
Yeah, thank you so much, Jen and Dr. Chu, for those informative presentations. We will now have IBD patients and caregivers share their stories and their personal journeys with ostomy surgery. And after they all share, they'll be available during the Q&A to answer questions that you might have about living with an ostomy. So our first patient story will come from Josh Nelson, and then we'll hear from Ernesto Llano and IBD parent Laura Schutzel. So Josh, I'm going to hand it over to you.
Well, perfect, and good evening, I should say, to all those who are attending. First of all, I'd like to thank the Crohn's and Colitis Foundation for inviting me to this event tonight. Also, Dr. Chu and Ms. Jen for providing the information to the people who are listening. I'm personally from Minnesota. I reside in the great state of Minnesota. I am 40 years old. I am married. I have 2 beautiful daughters. And at the age of 37, I was diagnosed with inflammatory bowel disease, ulcerative colitis, in November of 2017, following an inpatient stay due to multiple bowel movements that were happening every day in my life. The surgeries began 1 year later. I did not last very long on the medications. I had reached maximum medical therapy. I had been elevated to the level of biologics to include Humira, Remicade, and Tivio on top of steroids to help manage my condition. But obviously my body just did not respond to that. So at the University of Minnesota Medical Center, where I was inpatient with for over a month, it was decided to have my colon removed. So the first surgery was in November of 2018. I responded very well to living my life with an ileostomy, so I had decided to complete the final surgery in February of 2019, making my ileostomy permanent. And since that day, I have not looked back. I have not regretted one bit of living my life with an ileostomy. And the reason for that is because I was a prisoner in my own home when I was sick. I was having bowel movements upwards of 18 to 20 times a day. I was that individual that when I went to work, I knew where every bathroom was on my 40-mile commute to work, know where every bathroom station was, rest area, gas station. I can pretty much tell you where the best gas stations that hold bathrooms are, and they're pretty much holiday gas stations, but it was not any fun. I had no control of my life. I'm a very active person, as you can see by that picture right there. I am an Air Force pilot. I am a Lieutenant Colonel of the United States Air Force. And when I was sick, I was grounded from all of my flying duties, which really affected me a lot, basically because I didn't know what the future of my life held. So for Miss Jen, she can include an Air Force pilot because I am the first Air Force pilot to be allowed to return to flying status, having an ileostomy. And part of that was just due to my motivation to attain and get my life back. Since having the surgery, I am someone who lives with no medications, no special diets, and no restrictions. So I had goals once the surgeries were complete. That first picture you saw was me last summer when I was at my worst. I'm about 5'10". I was about 140 pounds. And that picture you see there with my daughters that I do the daddy-daughter dance with them every year because they're dancers. I'm back up to 185, 190 pounds. I have no fear with my life. I'm in the water. I'm extremely active. In the airplane, I'm able to take that thing from 300 feet above the ground all the way up to 25,000 feet unpressurized. And my ileostomy is the least of my concerns. And one little funny story I like to tell is we were doing a high altitude unpressurized personnel airdrop where Army guys go jumping out of the back and they free fall to the ground. And we're up at 25,000 feet doing this. And there's a little bag of Doritos that was sitting in the flight deck. And as I go up in altitude, that pressure decreases, but the air in that bag expands. So a little bag of Doritos, like everyone's ducking because they think they're going to explode. It could be like little daggers flying out all over the place while we're flying the airplane. And I thought to myself, I'm like, oh my goodness, what is my pouch doing right now? And I tapped it, completely empty, and no air had inflated. And the reason why that happened is because I prepare myself. So usually before I hop in the airplane, I will empty the contents of my bag, and it's not one concern that I have. Even if I had mistakes living my life with an ileostomy, such as a leak or some sort of issue, I tried to separate the emotion from that. I wanted to take a step back and really kind of figure, okay, what did I do wrong and what can I do better? I'm a very motivated type person. So the one thing I want to stress to people who are thinking about or are upcoming to having the surgery, like you've heard before, you can live a complete life having an ileostomy, colostomy, urostomy, any type of diversion that is out there. The surgeons that perform these surgeries are phenomenal. And like I said, the scary part is it seems like it's kind of a blooming era too of inflammatory bowel disease and kind of how it's, coming up on everyone's life. But I want to reiterate that I live a life with no restrictions, no special diets, and no medications. And from what Ms. Jen had said, an ileostomy can be a lifesaver, and I truly believe that. Having my ileostomy has saved my life. It gave me my life back. And I hope one thing that my girls can take away from watching me grow, living my life with an ileostomy, is that life is all about overcoming obstacles and how you work through those obstacles. So hopefully they can remember Dad when he was sick and the struggles that he had, that, I set small goals to hopefully work through all those issues in effort to get my life back. So to all those, I'll still be around to answer any questions that anybody might have. But thank you again for allowing me to participate in this event. Hopefully it can shed a little light on for some people, provide a positive story to live in a life with an ileostomy. So thank you very much. Again, I'll be around. And next I'll turn it over to Mr. Ernesto Llano.
Hi, everyone. My name is Ernesto Llano, and I'm an IBD patient and also training to be an IBD physician. I want to say, first of all, that this presentation has been excellent. And I keep thinking, I've had my ostomy for 11 years, and I keep thinking about how there was nothing like this back then. So it's super cool. But so I was diagnosed with ulcerative colitis when I was 16. And initially I got to remission with prednisone and 6-MP. You might know it as Imuran or azathioprine. And so those are just pills. And I felt okay with that for a couple of years. But then when I was a freshman in college, I started to get very sick. I was in a situation similar to what Josh described, where I was just having just constant bowel movements, had no control over them, a lot of blood, vomiting. It was terrible. I lived with diapers for like a year and a half or so, or 2 years, through like freshman year and sophomore year of college, which is not a great time to have to live with diapers. And so then I tried, obviously when I got sicker, I had to try different medicines. So I tried Humira and Remicade, and they never did anything for me at all, unfortunately. And I was being treated at Mayo Clinic at the time. I was also like Josh, I was living in Minnesota, and basically it got to a point that they told me that I had to choose between either clinical trials or have surgery. And at that point I was so just tired of being sick all the time, missing school, getting hospitalized, all of that. That I just didn't want to try the clinical trial because I had a sense I was just going to waste my time. So so I opted to have surgery. And so first I had, the first stage surgery where I had the ostomy, but still had the option to do the J pouch. But immediately, like I would say within a couple of weeks, it was evident to me that this was just so much better than what I had been going through, that I told my gastroenterologist immediately, like, oh, just take the other part out. I don't want a J pouch. I'm doing great. This has solved my problems. And they said, well, we have to wait a few months anyways or whatever. But I really never had any doubt about it, because immediately I was able to, like Josh described, just get my life back. And so anyways, it was awesome. My first thoughts were really like, oh my God, I'm so done. Why didn't I do this like a year ago or 2 years ago? So I had the second surgery a few months later, had my rectum removed, and then that made the ostomy permanent. I didn't want to have a J pouch because I was worried that I would have complications, still have to go see a gastroenterologist and all of that, and I just was frankly just over it. I wanted to have time to do all the other stuff I wanted to do. So so anyways, I had my permanent ostomy done when I was 21. I've had it now for 11 years. During that time, I graduated from college. I went to med school. I graduated from med school. I did residency, and then now I'm going to get some more training to become an IBD physician and scientist. So that means that, with an ostomy, you can do really difficult jobs. I mean, I can't say I've flown a plane with it, but I've worked 30-hour shifts in the ICU and things like that, and have had no problem. I'm married. I got married after having the ostomy. My wife and I recently celebrated our 10th wedding anniversary, and I've had no problem with like romance and intimacy and all of that. I mean, it was so much harder when I was sick to do anything, that with an ostomy now everything seems just like easy mode, and so we have two young daughters. They're 2 and 7 months, and I can do that with an ostomy. And I've traveled all over. I've been to India, Thailand, done stayed in hostels, like scuba dived. I have competed in some triathlons, and I play soccer in the university team, and I'm basically living a full life. I really can't think of anything that I would say, oh, I would do that, but I can't because of my ostomy. Honestly. So I don't take any medicines. I don't have to see my GI very often at all. And so I think something that is important to communicate to everyone out there is that really the ostomy, for some reason, has gotten the stigma where I think people think it's like much worse than it actually is. And so they end up tolerating situations like being really, really sick for a really long time, kind of unnecessarily, because there's this really actually pretty good option that people just don't know a lot about.
Hi there, my name is Laura Schatzel, or Laura Lichtenstein, and I'm an IBD caregiver. My son was diagnosed with VEO-IBD, very early onset inflammatory bowel disease, when he was 8 months. He had stopped eating. He'd had about 18 watery, bloody stools a day. He didn't take any milk. So he had a colonoscopy, and then we were told he has, they weren't sure if it was Crohn's or something else. So it's still called VEO-IBD in his case. So he had an ileostomy when he was 20 months. That's a picture of Jacob before his ileostomy. When he stopped eating and drinking, he fell off the growth curve. So he had an NG tube that we learned how to put in and feed him through that. And when it became clear that he was going to need feeding assistance for a longer period of time, he had a G tube, a feeding tube into his abdomen. So he also had chronic diaper rash from all these bloody, watery stools with terrible wounds around his tissue. And so we tried all kinds of medications. He was on steroids. We couldn't get him off steroids without him having a terrible flare. He was on 6-MP, various other things that I don't remember anymore. But because he was so young, there was a lot of medications that weren't available to him. So we were told about an ileostomy, and it became clear. Another thing became clear, which is that we needed to do that for him so that he could be nourished and so his colon could rest. So we had an ileostomy, and right after the ileostomy, the next day, I believe, he started eating. He started eating some cookies, and we were all rejoicing. He became a normal kid. He's still not even 2 at that point, but after that, he started growing. He learned how to talk, which he couldn't do before. He learned to eat, which he hadn't done before. Still a picky eater, but that's okay. So he's now 10 and a half years old. He's in 5th grade. When he was 8, we actually had the ileostomy reversed after many other surgeries, some colon resectioning, lots of things. Most of his colon was removed, and we got him on Veto, a medicine to prep him for this, and various other things to get him ready. We reversed it. And that was about 2 years ago. So he does not have a bag anymore. He has had some hospitalization since then for things that are probably related to IBD, like kidney stones and terrible flares, but he's great. He's on the growth curve. He's 30th percentile, which is really high, especially in our family. And he's great. He loves soccer, fencing, chess, and he loves video games. So some key tips, things that I found useful being a parent of somebody with an ostomy, is that they should always feel good about their body. Poop is normal. Everyone has poop, just has to come out a certain way for him. Always have your supplies, even if you think you're not going to need them. You never know. Just always have it there. This is related to the first note, but always be positive. No shame about it. If there's a leak or if you have to empty it, it's all good. Let's do this. This is great. Have a routine for emptying it. Involve the child in emptying it if they're old enough. Eventually, he was old enough to help unroll the drain pouch and even start to wipe it out. Have a routine for changing the bag. Have a place where you do it. Lay out everything. Have all the supplies right there, as you heard earlier. When they're young and they need distraction, a little iPad stand right next to the changing area works. We found elastic pants to be best for somebody that age. There were no off-limit activities for him. He took swimming lessons. He went to nursery school starting at age 3, especially once he was off of steroids. He was able to interact with other people, so ileostomy got him off of all the meds. And yes, get lots of samples from those manufacturers. They're really nice to talk to. Get all the samples to figure out what supplies work best. And it was the best thing we could have done for him when it was done. It gave us a little boy, and before he was a very, very sick baby. So we don't know what the future will bring, but we know that if we ever have to go back to that particular treatment, we will. Thank you all very much.
Thank you so much, Josh, Ernesto, and Laura. We have some comments of support coming in and how amazing and helpful everything you've said has been. Now I'd like to invite all of our experts and panelists to turn on their cameras and join us so we can take some questions from the audience. And as a reminder to those tuning in, you can submit your questions through the Q&A box and we'll try to get through as many as possible tonight. So our first one actually comes to Jen about this acronym that we keep hearing, WOCN, and what it means and kind of what the role of that position is.
All right, great question. So WOC, wound ostomy continence, is a specialty within the field of nursing. And you can, there's specialty training programs where you go to learn specifically about the needs of patients with wounds and ostomies and continence issues. And then you finish and you take a certification exam, just similar to you would take boards for, nursing. This is a certification in a specialty. And the WOCN Society has like a directory of providers so that you should be able to go there and search and find one if you have one local to you. But they can be found inpatient and outpatient, and they're kind of scattered throughout the country. There's not a ton of us, but I think more and more people are learning about these types of care needs for these patients, and I think that it's a growing profession. So it's an exciting time to be where I am.
Great. Thank you, Jen. I just wanted to open it up to Laura, Ernesto, Josh. Any experience that you've had with wound ostomy nurses and anything that you wanted to share?
I thought about becoming one or like assisting one. I mean, no, I don't know what you know, but we got training in advance, and then it was a lot of trial and error, and it was a lot of trial and error. And I should also say that we were very lucky. We are very lucky because my spouse is a physician, so he was able to, I mean, a totally different specialty, but that helped in giving me the confidence to learn all these things on a small moving baby.
So we definitely love our IBD care teams from all different specialties. They're all helpful. Just wanted to open it, Ernesto or Josh, anything that you wanted to add about wound ostomy nurses playing a role in your care?
I would just say that, I've had my ostomy like 11 years, and I learned a bunch of stuff during Jen's talk, so I should probably be making an appointment.
Glad to have you.
Great, thank you. Our next question, I'm going to aim at Dr. Chu. We got one that said, what happens to your immune system after an ostomy? And what happens to your, quote, important gut bacteria?
Yeah, so great question. So overall, from an immune system standpoint, I don't know that there's any changes. That when you have an ostomy, it's essentially a hole that is somewhere along that whole kind of intestine where waste is now coming out. So essentially, an ostomy is just another point, a geographic location for stool to come out. So it doesn't really affect your immune system per se. Now, when you talk about the bacteria and the microbiome, that's a little bit different. And so there probably are some effects. If someone has an ileostomy, that means all the stool is coming through the ileum, nothing is going to the colon. And so there may be some effects there. And I'll say the science isn't great. We don't know what changes happen. The biggest change that does happen though with ileostomy versus colostomy has to do with nutrition. I think that's the biggest thing, meaning your colon absorbs water. That's the whole purpose of the colon. So if you have a missing colon or an ileostomy, your ability to absorb water is going to be compromised. So you're susceptible for dehydration and losing too much water from an ileostomy. And that's probably the number one complication of having ileostomy is dehydration. Now, having a colostomy, that's in a sense a little bit better because you have your colon, so you can absorb water. Now, sometimes people have ostomies, small bowel ostomies, that are really proximal, like they're in the jejunum, the middle piece of your small bowel. And that causes more problems from nutrition because your ileum actually does a lot of nutrient absorption. So individuals who are missing the ileum, they may have some issues with that. So a lot of it just has to do with the anatomy, the geography of where that ostomy is.
Great, thank you for that overview. And we have a post-op ostomy question. Do patients need to take special vitamins or supplements? And can you take a pill versus liquid, and kind of what is the difference there? So I guess we can start with Dr. Chu, and then maybe Jen, if you wanted to chime in after.
Yeah, I think Jen will have a lot to say here. So certainly there is an effect when you have a small bowel ostomy, like an ileostomy, or even something more proximal. Certainly it's a quicker transit time from the mouth to the ostomy. And so patients absolutely describe taking pills, and the pill is in the back with an ileostomy. Colostomy is a little bit further downstream. And so that I think is less in terms of when people see that. From nutritional supplements, I will say that I don't routinely prescribe any supplements except in cases where it's a really proximal ostomy and patients are not using their ileum. That might be the only reason that you might need to give some vitamins.
Yeah, I would agree with Dr. Chu. I think, there is some role for supplements in patients with stomas. Particular ileostomy with like a vitamin B12 possibly being an issue. But routinely, in terms of routine prescription, I don't think that there's really any need for that. I do think that there is in the post-op period or even in the pre-op period, there's room for looking at what medications the patient might already be on, what's extended release, and what might be expected to come out in a pouch and may need an adjustment or a tweak either pre or post surgery. And to keep an eye on the contents of your pouch, and if you do see whole pills, tell someone about them so that you can make a plan and figure out what to do.
And I would say that the most common pill that a patient with an ostomy might take is pills that really affect the motility, I should say, of your intestines. So as I said before, the ileostomies can get really high output and put out a lot of liquid. And so it's very common for patients to have to take medications to slow down the small bowel. Things like Imodium, things like Lamodal, tincture of opium. Those are all medications that are all designed to slow down the intestine to give more contact time for that small bowel to absorb all that water.
That's great advice. Thank you both. And Jen, we have a question about with an ileostomy. Do you find that there are any foods that are off limits, such as raw veggies, salads, maybe some typical things that patients might stay away from?
So I think initially post-op, there is a slew of different food items that have, there's soluble fiber that your body is able to sort of digest fairly easily. And then there's items that have a lot of insoluble fiber, things like nuts, corn, raw veggies, those kinds of things that in the immediate post-op period with an ileostomy, you want to be very careful of. We usually tell our patients, to follow the standard American diet sort of post-op, in that, you usually go to your doctor and they tell you to follow and do whole wheat, this and that and the other things. But in the immediate post-op period, primarily focus on more of like the white breads and those kinds of things, because it's easy for your body to digest and sort of avoid raw veggies. If you want to have vegetables, if you want to have fruits, cook them down initially. But if it is a situation where you're going to have a stoma for a long period of time, I think there's room to, after you've recovered from surgery, incorporate some of those foods back in your diet. Maybe some of them you might have to have in smaller quantities, and make some adjustments. But I don't think there's truly any really off-limit foods.
Great. And we have a patient, this one is for Dr. Chu, whose daughter had her colon removed due to severe UC a couple years ago. And she tried step 2 to make her J pouch, but was unable to move forward. So how long between then and now, or does she need to decide whether or not to make her ileostomy permanent?
Yeah, thank you for that question. So certainly it's going to depend on the situation. My big question would be, why it couldn't proceed, whether there's something going on with the remaining rectum. But what you're describing is the classic stage kind of 2 out of 3 procedure for ulcerative colitis, which is where stage 1, you take out almost the entire colon, you do the endoileostomy, and you leave this rectum as a blind end, just for some time period to recover, because patients are usually very, very sick when you have to do that. And then I think the participant is referring to the stage 2 procedure now. Now, certainly from stage 2 to a J pouch, that is a big decision. And I would say that there's no rush. That's probably the first thing. If there's nothing else pressing the issue, like a cancer, in my mind, that would be the one thing that might force the issue, then you can wait. And there is time, because the rectum's there, the ileostomy is there working, so there is a way for the stool to come out. So in that whole time period, you're recovering, you're getting stronger. Patients, you're working on medications if you need to, before you finally commit to that J pouch. And as Ernesto and Josh have alluded to, the J pouch is a big decision. Certainly, it's not. There are no freebies in surgery, as I tell all my patients and trainees. Everything has a risk and a complication that could happen, and so that decision, I think, is going to have to just be a really carefully made shared decision between you and your IBD team, both, not just the colorectal surgeon, also the GI doctor too, and the whole family, I think, to make that call. But as you can see from the session today, we have just, really inspiring stories, I think, about a decision where no J pouch was made. So the J pouch is not, you see it all over the web, that is like the answer to everything, but actually it's not. There are alternative surgeries that can be done.
Great, thank you. This next one, I'm going to ask our patients to chime in. So we can start with Ernesto and then maybe Josh and Laura. How do you bring up your ostomy to someone who doesn't know about it? And Laura, for you, how do you bring it up to the people around your child, whether it's people in school or other family members and friends? So Ernesto, do you want to start with that one?
Yeah, I totally agree with what Laura said of being kind of very shameless and open about all this stuff. So I've done it so many times, and that it really doesn't faze me at all anymore. But it was a little bit harder the first few times, but you get used to it. And yeah, so I just, let's say if I'm talking to someone and they ask me, but so sometimes it comes up because I'm a doctor. So they ask me, oh, how'd you get interested in medicine? And I say, oh, it's because I went through this. And that's a very kind of natural segue into it. But sometimes it's been a little bit kind of a more awkward situation where we're gonna like go to a swimming pool together, or go to the beach together or something, and it's someone that might not know. And I'm like, well, it's kind of rude to just like, take my shirt off and have them wonder like what this thing is or whatever. It's just natural curiosity. So I would just tell people like, oh, hey, just so you know, I have this like ostomy bag. So when I have my swimsuit, you can probably tell. And then they're like, usually a reaction is like, wait, what? And I'm like, yeah. And they're like, well, but you can go swimming and stuff. I'm like, yeah. Like, so that's just kind of how it goes. I think basically people will make as big a deal out of it as you want to make it. So if they can tell that it's really not a big deal to you, then they also treat it like it's really not a big deal. People will kind of mirror what you do. So I think if I said like, oh, I have to be careful because of my ostomy, and was secretive about it and whatnot, I think people would think, oh, that's really a big deal. But because I treat it very casually, then people mirror that and they don't care about it either. So that's what I would recommend.
That's great advice. Thank you. Josh, did you have anything to add there?
Yeah, for me, it was, like I said, my big goal was getting my life back and getting back to a sense of normalcy for my family and also myself. And I agree with what Ernesto just said. It's, I do not think having my ileostomy is a big deal at all. Like I look at it as my lifesaver, and I 100% agree with him. Like if I don't make it a big deal, or if I'm not self-conscious about it, like you saw in that one picture, I wear a stealth belt for my appliance. So when I'm in the water, I wear a two-piece appliance. So when I'm in the water, I just turn the thing horizontal, suck it into my stealth belt, and it's no harm, no foul. I mean, kids will come up to me like, is that a fanny pack? Like, yeah, it's a fanny pack. So I just kind of deflect the situation. But yeah, I think there is a sense of curiosity out there. And if someone does ask me, I'll tell them, yeah, I have an ileostomy. And it usually turns into, well, what is that? So then you kind of give me your little 3-minute spiel on it, and they actually find it quite remarkable. Some of the conferences I've been to, and I'm sure like our medical staff knows, and even Ernesto and Miss Laura know, kind of, how far the appliances have come in technology, the neutral tones of them, the colors they make them to kind of make everything blend in. I go to the gym 6 days a week, and I bet you half those people don't even know I have a stealth belt on underneath it. Like things are so nice for concealment. But like I said, I'm totally proud of my ileostomy. I'll be in my house, walk around with my bag hanging out and no belt on. Like I said, I don't care. I'm pretty fortunate that I've had a really good recovery with it. And I mean, I don't know how Ernesto or how Miss Laura's child was, but I mean, I change it once a week, twice at most. And it usually comes down to how much I sweat, because that will break down the wafer. So if I'm, you think of the summer times in Minnesota, if I'm down south, there's more humidity, your body perspirates more, it's going to start to break down that wafer, versus now in Minnesota, it's getting colder, it's getting drier. So, I mean, I change it just to kind of keep the skin healthy. And I am a guy, so I do have some body hair. And if I keep it on longer, taking that wafer up becomes a little more painful. So I try to, keep the area clean and dry. But I 100% agree with what Ms. Jen said about the care of any type of appliance is less is more. I mean, I wear 3 pieces. I don't use a lot of skin prep at all. I pretty much hop in the shower, scrub everything down, swap out the piece, dry it off, and put the new one on. And like I've mentioned before, it's kind of like when you put the new one on, it's like there's a new pair of underwear on. It just feels good, So that's my mentality behind it. I'm not afraid of it. And if anybody asks me about it, I'll be more willing to tell them about it.
Yeah, I will say that sometimes I've concealed it accidentally. So like I had a friend in med school that we were friends for 3 years, and he didn't know I had an ostomy, and we're close friends. And I had no idea that he didn't know, because I talk about it all the time. So I just assume that people know. And then one day we're sitting around the table, and then someone starts talking about, asking me questions about the ostomy, and he's like in shock. And he's like, hold on, what? Like, you have an ostomy? I was like, what? You didn't know? And I mean, so yeah, you can. I will say I think it's easier with men's clothes than with women's clothes. But at least with men's clothes, I find that it's very easy to conceal. A lot of people don't know I have it, and it can even become kind of a problem, because like I have to tell them, because otherwise they won't know. But anyway, so I haven't found concealment to be a problem. I have a couple of friends they're sort of friends who are women and have ostomies, and I've kind of met through ostomy groups and stuff, and they have mentioned that it can be harder to conceal it with women's clothes. So I don't want to kind of speak for everybody, but at least, you know, that's been my experience.
That's great. It kind of proves that, you know, you can share what you want to share and what you're comfortable with, and that's all you have to do. And Laura, kind of the same question to you. I know you said that your son had it very young, but how did you inform the people around him, and how did you speak about his pouch with others?
So it's almost the opposite of what Josh and Ernesto are saying, which is that we decided to make that it was Jacob's story to tell, that it is Jacob's information to share, if and when he wanted to, and even when he was too young to sort of, because he also, the other thing that's interesting is that he didn't know any other way. So like he called it his stoma Chewbacca or Chewy, because it made the, you know, the grumbling sound. So it was just Chewy, you know, and that it was very important to us for us not to tell people, so that, you know, when, I don't know if kids seem pretty friendly, but it just needed to be a private issue for us, except when we had to tell people, like at daycare or nursery school. We didn't do the 504 route, although we were in New York City public schools, so we could have done that, but we didn't want anything special. He and his kindergarten teacher had a special, like if he went like this, she let him go to the nurse to get it emptied. So it was all very private. And then it would be like between, like, what I had to tell some mommy friends, you know, because they would complain about nap times. And I was like, yeah, well, I have a, you know, not so much for that, but looking for, you know, when people share, and it was always, I always preface it with, this is confidential information. And same with telling his teachers in the school, this is confidential information. One pre-K didn't want to let us in without having an aide, and I withdrew my application. But other than that, every place was open, but it was understood that it was not public information, not for shame, but for privacy for him.
And I will jump in and just say that makes a ton of sense, because there you're trying to think about how to handle that for somebody else, you know, and you have to be much more sensitive to that. I'm just, you know, I'm the only victim of my actions, you know, so but I could definitely see, like, if I had a child, you know, because Crohn's has and UC have like a genetic component. So if I've thought, you know, what if I have a child who then has this? I think I would probably take a similar route with them until hopefully they felt comfortable enough to have this same kind of attitude, but I wouldn't want to make that choice for someone else.
That's great. Thank you so much. We are coming to a close, so I'm just going to, as an end question for everybody, and we can start with Jen and then work our way around. What is the best way that patients and caregivers can mentally prepare, mentally and physically, prior to ostomy surgery for themselves or their loved ones? So Jen, what do you think?
I think with anything new, ostomy surgery, no exception, information is key. Try to prepare yourself by going to reputable websites like UOAA or Crohn's and Colitis. And there are definitely some very helpful YouTubers out there who you can get accurate information from, but you just have to be careful with that. And I think if you have the opportunity, you know, to see if you have somebody or access to someone in your life who has a stoma, that is also a good route to go to kind of understand the path that your life you may travel should you choose to pursue surgery as an option.
Great, thank you. Ernesto?
Yeah, I think my final words would just be to say that if you're suffering a lot from IBD, or you know someone who is, let them know that to just look into this and research it, and not just write it out, or, you know, accept the stigma that that's out there.
Great. And Dr. Chu?
Yeah, so, you know, we always say that the surgery is always one part, and that's the part we can control in the operating room, but a lot of the work is done before the operating room. And so all that time that needs to be spent in the clinic, at home, kind of communicating and learning about and understanding what it means to have an ostomy is the key. And so I think, you know, organizations like Crohn's and Colitis Foundation, the ostomy associations, and in peers, you know, we have patients who will ask us about ostomies and ask if they can communicate with another patient who just had an ostomy. I think that's honestly the best way to be in a safe space to ask the questions that you want to ask that you might not feel comfortable asking the providers and the nurses. And so we try to do that and try to create that link between peers who've just had an ostomy.
That's great. Laura?
Sorry. Yes, all that was said, and any way you can demystify it. And, you know, to pick up on Dr. Chu, what you said about meeting other patients, that was the best thing for us. I mean, it was after he had it. It was hard to find a connection because of HIPAA violations. So it was really like a friend of a friend of a friend, doctor's friend, you know, so, but talking to somebody else was good. And finding someone like Nurse Jen would have been great.
Thank you. And we'll end it with Josh. Any last final thoughts?
Yeah, I agree with what everyone has said so far. Obviously, information is key on anything that you do. Asking the difficult questions. Don't ever leave any rock unturned. The last things I'll kind of close it out with is, you know, everybody handles any type of ostomy differently. There are a lot of generalizations out there, you know, when it comes to food, diet, whatever it may be. Have an open mind, because, you know, what might work with one person may not work with you. So you can't always take what they say as for granted. There is a trial and error period of you learning how to live a life with an ostomy, but it's not difficult at all. You know, break the stigma is one thing I like to think about. It is, you know, it seems like anything that is not normal attains a stigma. I think living a life with any type of ileostomy is completely normal. It is not life hampering at all. You can do anything that you want. If you're one of those ones reaching out or trying to find somebody who does live with an ileostomy, I get consulted with quite a bit with people in the Minnesota area, because I have been put on the TV with a local news station. They're always like, who's that guy? Like, can we get a hold and ask him questions? If that's you, please call. I think myself, Ernesto, anybody on this panel, Miss Laura, are only here to try to help and guide you in a specific direction, try to give you the positive information that you may be looking for. We don't have all the answers. We're not the experts, but I think we are experts in our trade, that we have lived our life with an ileostomy or any type of diversion that may be out there. So yeah, I'll leave it with that. And thank you again for letting me attend. So appreciate it.
That's a great note to end on, and I want to encourage all of our audience members to please reach out to the Crohn's and Colitis Foundation, our IBD Help Center, our newly launched ostomy resources on our website. Please check them out. This was a lot of great information, and thank you so much again to our expert faculty and our panelists for sharing your perspectives and your knowledge with our audience today. Before we end, I want to remind everybody to please fill out the evaluation survey that will be available for tonight's program. We really appreciate the feedback, and it'll help us plan for future programming. Before we say goodnight, we would like to invite you to view your local chapter's upcoming events on either their foundation website page or their social media page. We again want to thank tonight's sponsors, Gilead, Janssen, Takeda, and Bristol Myers Squibb, for their support of the MyIBD Learning program. And we hope to see you at our next webinar on November 18th, which will be on navigating eating around the holidays. Thank you so much again, and hope everyone has a great evening.